Okay. So this is part of a new study method that I've been testing where I will be going through each of my flowcharts that I've made for this block, and in the process of teaching it to myself, hopefully teach it to other people maybe, but most likely just for myself when I inevitably forget everything, which is really a pattern, me forgetting stuff. I have my old charts here in case I ever want to reference these again. But in undergrad, I used to make these. And they were really good, but I forgot everything. And now I'm starting pretty much from scratch. Let me show the other one here too, in case I lose the file again, which I often do. These were the two major whiteboards that I made from undergrad. One on all of the cell development and differentiation, and one on T and B lymphoid development. So I'm not going to bother with that for now. I'm just going to go in and look at the topics that we've been learning for this block. So I'm going to start with the core of hematology and immunology, ones that are basic introductions, the formed elements, and red and white cell kinetics, which is talking about the lifespan, life cycle of them. Then I'm going to go on, and I'm actually going on to the myeloid cells first. So I'll be going into platelets, talking about coagulation and the disorders associated with that. And then going on to red blood cells right here, looking at thalassemias and hemoglobinopathies. These are both problems with hemoglobin. And I'm also going to talk about hemolytic anemias, which is pretty related to the immune system as well, but I'm just going to cover that first. And actually, when I talk about immune hemolytic anemia, I'll save that for last so that I can talk about complement as I'm talking about hemolytic anemia. I'm also going to talk about the megaloblastic and microcytic anemias, which are in relation to nucleotide metabolism as well. So that's going to be myeloid, and then after myeloid, I'm going to jump over to innate, talking about complement and the innate immune cells. And then while I'm there, I'm going to be talking about the adaptive immune system with the lymphocytes, talking about the introduction to cytokines and the immune system. And then I think it makes more sense to talk about B cells first, just because that's how it naturally takes place in the body, talking about the T cells first, and then after that talking about their effect on B cells. Right, so this is the classic APC to humoral response that we get. We get innate T cells and then B cells, and then we're going to talk about not just the development but also the function of each of these. And we're going to talk about vaccination, amyloidosis, which are problems with B cells or treatments involving B cells. And then after we get a feel for normal immune function, we're going to jump over to inflammation, and we're going to talk about transplantation, and we're talking about immunosuppressants and all the things that they are for, which is when your immune system is going haywire. When we're done with that, we can talk about when the immune system is really messed up, right? And we can talk about infections, HIV, and we can also talk about neoplasms with all the blood cancers. I want to save that for last because that one's crazy complicated. and because it'll integrate, I think, a lot of the things that we've been learning already. So I'll put that last. And I forgot to touch on this anemias portion, but I'll save blood transfusions for the hypersensitivity period, even though this is a treatment for anemias, right? And also drugs affecting blood formation. I think I'll talk about that. I think I'll talk about anemias in general after talking about inflammations. So I'm going to do that. I also should have thrown immunodeficiency over here because technically it could be a cytopenia, right? But it doesn't have to be. So that's sort of the plan. And I'm going to quickly check that this thing is recording audio because it would be a major bummer if I was talking forever and it didn't end up recording anything. That would be bad. Okay, so if I was talking forever. It's working. Okay. So yeah, let's jump into number 1, formed elements. Right. Formed elements. Okay, so our main player for anything blood related is our hematopoietic stem cell, which is pluripotent and lives inside of the marrow. And that stem cell will then differentiate into our 2 major progenitors, which is our lymphoid and our myeloid progenitors. I'm going to be focusing on myeloid first because it includes a much broader group of cells, which includes the red blood cells, the platelets, and all of our granulocytes and our monocytes, which are leukocytes, immune cells. So I'm gonna talk about that first, and then after that go on to lymphoid. So classic myeloid cell that we like to talk about is our red blood cell. So I'm going to talk about that. Red blood cell is non-nucleated, and the most important protein that's found inside of a red blood cell is hemoglobin. Hemoglobin uses iron, specifically the 2+ cation of iron, to hold on to oxygen and transport it throughout the body. It changes conformation based on different environmental conditions, which helps it release oxygen better in specific areas. But we didn't focus too much on that. It's a bit of biochemistry that I will not talk about. And so let's go over how a red blood cell is made. Red blood cell starts off as a proerythroblast, so that's when it commits to being a red blood cell, as opposed to any of these two other lines. And it's a big nucleated cell, as are all the other blasts. I guess we could say all the blasts have big nuclei and a lot going on in their nuclei. So what stimulates a lot of production of red blood cells is an important signal called erythropoietin. And the signal to create more erythropoietin, the signal to create more red blood cells, comes from the kidney when there's hypoxia at the kidney. Why the kidney specifically, I'm not too sure. But what we do know is it's a signal from the kidney going to the bone marrow to tell our blast to make more red blood cells. And so once it gets a signal, it's going to make erythroblasts, which is our first stage towards our mature red blood cell. Notable appearance features of the erythroblast. You have chromatin clumping. What does that look like? Don't know if I can get a photo. I could also pull up the slides for some of these. That's abnormal. But yeah, let's do it. Let's talk about, let's see if I can pull up images. One of my biggest weaknesses is that I don't have enough images for some of these things. So for each of these, I'll pull up the slides too, just to reference, in case we need to know what something looks like. See if we can get this. We're looking for clumping. So here is an image of our clumping in the proerythroblast. So we have a lot of heterochromatin. So this is when we're starting to change from a normal nucleus to a pycnotic nucleus. So we're starting to get more and more methylation of the DNA, and that's going to create our erythroblast. And even in the erythroblast, there's a few substages, as you can see here. These are all called erythroblast. Essentially, if it has a nucleus and it's on its way to being a red blood cell, we call it a blast, right? So these will change color over time, going from blue basophilic, which means it grabs the blue dye, the blue basic dye well, and then becoming more and more red over time. So that's the polychromatophilic. It has red and blue, and it's going from blue, red and blue, and then finally to our red. And that's our blast. So blasts in the marrow only. Reticulocyte is when we are really close to getting our full red blood cell, is when the nucleus is already out, but we still have a little bit of ribosomal material left. So it looks like a net inside of the red blood cell, right? And sometimes these will be outside of the red blood cell, which is a major problem. It is a signal for a major problem, right? And finally, we get our full red blood cell. No nucleus. It lives 120 days, which is pretty good. 4 months is pretty good. It has a lot of different glycoproteins on the surface. And here's the basic structure of it. Has glycoproteins. It has a lattice of spectrin. If we can get a photo of spectrin over here. Here's more photos of the proerythroblast, basophilic erythroblast. So I wouldn't be able to tell the difference between this and other blood cell blasts, but you can start to see later on that it looks better. But yeah, the blast is kind of hard to tell. It's big, blue, nucleated, not really easy to see. I'm trying to find right now the spectrin lattice. So spectrin has this net-like form, and there's a few attachment sites that are involved, and it connects the ankyrin, which is what we see here, with the actin that's inside of the cell. So overall, it's going to be connecting the two and forming that layer. There's a few types of ankyrin as well that I have listed here, band 3, band 4.2. but its general purpose of both of these is to be an anchor. Actin, intracellular, and chirin is a membrane anchor. I think that's the best way to think about it. And in the breakdown of a mature red blood cell after 120 days is phagocytosis, and then it turns into ferritin, and then hemosiderin. These are the storage molecules that are found mostly in macrophages. So that's red blood cells. Then I'll go on to our thromboid, which is our platelet line. Platelets turn into, they derive from megakaryocytes, which are these big boys. Oops. Which have a single nucleus, sort of, but it's really split up. I don't really know how you would tell the difference between a megakaryocyte and a multinucleated giant cell. Let's see if I can find a distinction right now between the two. So giant cell is truly multinucleated, I guess you could say. You can really see individuals, whereas the megakaryocytes one is sort of less defined. Also, you don't expect to see the giant cells in the bone marrow, right? So I think that's good enough for us to tell. If it's marrow and we can see these multinucleated cells, sort of, then that's probably megakaryocyte. So megakaryocytes have a weird sort of mitosis that's incomplete, which causes them to have way above the ploidy of a normal cell. And they also have these demarcation channels, which help them to break more easily as they're being sort of extruded into capillaries and into the blood. If I can find something for that. Here it is, I think. Yeah, so it's just coming straight through that narrow opening and going into the sinusoids. I don't think I can really see the demarcation channels, but they're there, apparently. And so then they turn into platelets, which last 10 days, and they're a lot smaller than the red blood cells, which are 7.5 microns down to 4 microns. So about half the size of a red blood cell to maybe a fourth of the size of a red blood cell. And the main thing that we have to know about the granulomeres is not necessarily what's inside of them, as much as the fact that there are a lot of ingredients inside of a platelet, which includes the fibrinogen, which we'll talk about very shortly, the platelet-derived growth factor, the calcium that's necessary for some of this clotting, and there's also lysosomes in there as well. So that is platelets. Let's get a better look at a platelet as well. They sort of look like this. They say they're biconcave, I think, which pretty much just means that it's a little knob-shaped cell. And I think I wrote my thing wrong. There's delta. I wrote beta in my thing, but alpha has the platelet-derived factor, and delta has the serotonin, and everything else. I had to change that. So that's the platelet. All right. I'm going to go on to myeloid, progenitor line of granulocytes and monocytes. We're going to talk about this one right here. I think there's a progenitor called the granulomonocyte progenitor. If I can find it. Can't find it. Lymphocytes. There's a shared progenitor for these. But anyway, that granulomonocyte progenitor splits into the granulocytes and the monocytes. Monocytes, which are about twice as big to 3 times as big as a red blood cell. They live about 8 hours in the blood, but they quickly go into peripheral tissues where they can live for much longer. Those are called macrophages. They can be called Langerhans cells, but yes, there's a lot of resident monocyte lineage cells. And let's talk about granulocytes as well. These are the ones that degranulate and are often involved in our immune responses in the blood. So when we talk about that, we can talk about development and then talk about how they turn out. So there's the myeloblasts, which let's see if we can get a photo of a myeloblast. I don't think there are that many good photos, but a myeloblast will probably look very similar to our erythroblast in the sense that it's a big cell with a big nuclei with multiple nucleoli. That part is the same. I think the only thing that we can really tell is the difference between these blasts is the fact that they have different cell markers within them and they're headed in different directions, but they should look pretty similar. So our myeloblast turns into a promyelocyte, and it actually gets a little bigger when it's doing that. So the promyelocyte is the biggest one, and that's where it gets its primary granules. So it's also called the eosinophil granules, which has our basic lysosomal components. You know, our basic of any phagocytosing cell has the lysosomes, and so it'll have lysozyme, defensin, myeloperoxidase to break down what it phagocytoses or what it releases. So then it will turn into a myelocyte. Get a photo of that. Right here is when we start to get some specific granules, right? And then we go to metamyelocyte, is when we have a lot of our specific granules, and smaller Golgi apparatus, although that's not that important. The main thing that I think we need to think about for that is that the nucleus becomes more and more horseshoe shaped, less like a ball. And then that'll turn into a band granulocyte, which if you can see here, a band myelocyte. I don't think I have a photo here. But it's right here, yeah, band myelocyte, which has a horseshoe-shaped nucleus. This is the point where it starts to enter the blood. So it's, I guess, analogous to a reticulocyte in some ways. It has a immature, but pretty much there in development. And then we'll have our segmented, our fully adult granulocytes. And the segmentation of the nucleus is actually pretty telling. Eosinophils always have two. Basophil could have 1 or could have 2. And neutrophils have a lot more, usually 3 or 4. No more than that, though. If you have more than 4, you start to get other things going on. And neutrophils also have bar bodies, which are inactivated X chromosomes in women. I was really dumb, and I thought I saw a bar body, even though it was not a woman's blood sample. So, anyway. So our granulocytes, we have 3 main ones, and this was actually really hard to remember for the longest time because these names don't seem very intuitive, but they really are, because basophil just means base-loving, right? Neutrophil, neutral, and eosinophil, acid-loving. So base, neutral, acid. And the base-loving one, the basophil, is stained because it has histamine. Histamine, which is very involved in allergic reactions, and it attracts the basic dye. Basophils are covered in IgE, these kinds of Fc receptors. What happens is the B cell releases these IgEs, and then the IgE will attach to the basophil and coat the outside of it, so it'll wear it like clothes. And if that comes into contact with something, then it will send a signal to the basophil, where it will then degranulate and cause a allergic response. In some ways, they're pretty similar to mast cells, but the only difference between those two is where they originate from. They have similar functions, but they originate a little bit differently, because mast cells mature later. They're like the late bloomers, versus basophils, which are trained and are immediately doing this job. And all of these have azurophil granules, as we were talking about earlier, because all of them go through that pro-myelocyte stage. Only when we hit that, only when we hit the myelocyte stage do we start to see the more secondary specific granules. And CD40 ligand, I don't quite remember what I was talking about. Oh, basophils can stimulate IgE. So they stimulate the B cells to make it, and then they wear the clothes. They wear the IgEs as clothes. So they have a team-up relationship. I'm going to go past neutrophil, go to eosinophil first. Eosinophils love acid, and they stay in red as opposed to blue. And instead of histamine, right, they have histaminase, which helps it to chill, like cause the basophil to chill out a little bit if it's going too crazy. And it also has its own type of granules, the major basic protein, which is for killing worms and parasites. So eosinophils for parasites, basophils for bigger allergic reactions, and then neutrophils, which are the most common cell. They're, I want to say, the suicide bombers of the body, really, because they go out en masse and then they degranulate and they die. That's what my professor liked to say all the time. Degranulate and die. And they have beige granules. So the secondary one helps it to move around more easily. Better mobility. The secondary one is for better killing. You have lysozyme, lactoferrin. So this is so that it can destroy more efficiently. And then the tertiary is for mobility. Tertiary, you have metalloproteinases. It can break down basement membrane. It can break down extracellular matrix and go to where it needs to go. And part of that is through chemokines, and it needs a lot of machinery here in order to leave the blood as well. The P-selectin, the integrin, the ICAM, in a process called diapedesis, or I like to say extravasation. And the thing with neutrophils are that there are so many of them. In fact, they comprise most of the white blood cells. So we need to think about where they are in the body at any one time. So they could be in the marrow, or they could be in storage. Normally they're in storage somewhere, either in the marrow or near the marrow, where they're ready to just get released in just a storm of them. Right? There's some that are circulating. There's a certain number, and there's some that are marginating, which are on the vessels, and they're just sitting there. So they're not in the liquid blood, but they are on the vessels. So they're technically, still systemic. They're still patrolling. So those are our myeloid cells. So I'm going to go on to lymphoid cells right here. Lymphoid cells are the easiest way to think about them is that they're from the lymph. They can go to the lymph. And the one that works with the innate immune system is our natural killer cell. Actually, let's start in order. So the T cell, we have T helper cells and T cytotoxic cells, which are related in killing cells, killing foreign bodies. But our T helper cell can also activate our B cell and cause us to have plasma cells and antibodies. And the T cells can also activate B cells, and the B cells can activate the natural killer cells through ADCC, where the natural killers will not only kill the cells that they're innately programmed to kill, but they can also kill cells that are labeled by antibody. These are non-adaptive normally, but they can be prompted to do some specialized killing. So that's a summary of our stem cells. Let's see how I'm going on time. 30 minutes. I'm about twice as fast as the professors, which is it's better, but I'm not that fast, I guess. There's a lot of content. Hopefully I can put it in a better way, though. All right. So now that we've done our formed elements, we can talk about our kinetics. So we were talking a little bit about marginating versus in circulation versus in storage, and we were doing that for neutrophils. We should also do that for the red and white cells in general. So we're going to go look at that now. Okay. So we can talk about normal kinetics first, and then after that we go into the pathologies. When something is messed up, how does that look in our peripheral blood? So normally, red cells are produced in response to erythropoietin, which, as we said earlier, is signaled by renal hypoxia, which makes sense in some ways. If we have fewer red blood cells, our oxygen's not getting carried enough. If our oxygen's not getting carried enough, we need more. We need more red blood cells. We need more delivery. Chronic renal failure will cause you to create less erythropoietin. So any renal damage that's really bad is going to make you create less red blood cells. The signal is going to be lowered. We're going to talk about this later as well, but when you have a cancer of the red blood cells, they're going to care less about erythropoietin. They do whatever the hell they want. So they die after about 100 to 120 days, about 4 months, where they get phagocytosed, and then their iron gets stored in the macrophages, and this is normally done extravascular. This is normally done outside of the blood vessel. They just get taken out by mostly the spleen. They get taken out and phagocytosed there. So the breakdown process, they get turned into hemoglobin by the macrophages. And if you normally the process will also involve a full breakdown, which will cause you to excrete it. So it'll turn into, if you want to excrete it, it'll turn to bilirubin, and then it will turn into conjugated bilirubin, where it can be processed at the liver. And you either excrete it. I'm pretty sure you do excrete it at that point, but I'm going to have to check on that. I think we're going to talk about this a little bit more when we go into our anemias, where the iron goes. I'm not terribly sure right now. But as for white cells are mostly comprised of our neutrophils. And so our neutrophil count is going to be pretty close to our absolute count of white blood cells. Right? But it can also be broken down into our differential. So CBC and absolute count. CBC is our, CBC is our total white blood cell count, which happens to be mostly neutrophils. Which can be affected, can be increased or decreased depending on the situation. But we can also break it down more specifically and look at how many, say, lymphocytes, how many granulocytes we have. So we can break it down into a differential, and we can also break it down to an absolute count of, say, how many granulocytes we have or how many neutrophils we have. Okay, so I'm going to talk about neutrophils first because that's our biggest contributor. So this can either involve a pseudo change where we think we see less. Well, we do see less, but we think that's because there are less, but it's not actually the case. We just happen to see less when there are actually a normal number. And this can happen either when you have more that are marginating, which can be a result of anesthesia. I don't really know exactly why, but I guess with anesthesia, they will just stick to the walls of the vessels more easily, and you won't get it in your sample. Versus if you had increased blood flow, all of a sudden, or you're exercising or something, they can probably get pulled off of the vessels and start circulating in the fluid blood. So that's a pseudo change. It's not actually more or less neutrophils. It just looks like there's more or less. Versus what we have as a true change, which can either cause a failure of the neutrophils to leave the vessel, leave the vessels and enter the tissues. So that can be as a result of steroids. So that will increase our neutrophils. Or it could be a change in the marrow itself, where the marrow is actually producing more or less. So if it's making more, it can be the result of an infection, which is a leukemoid reaction. It's when we have a ton of white blood cells, and it even looks a little bit like a cancer, but it's really not, right? Or it could be an actual cancer, leukemia, when there's tons and tons of white blood cells. It could also be a neutropenia when we have not enough neutrophils, which can either be because we have a marrow problem, we're not making enough, or we're using a lot to fight an infection, for example. Okay. And then for granulocytes, they have a compartment as well, just like the neutrophils we were talking about earlier. They can be in the marrow, they can be peripheral. Almost always, as we've been talking about, the storage pool is always, a lot more in storage than there are actually out in the body. But it does tell us a little bit about maturation. It takes 6 to 12 days to mature before it goes into the blood. And then this is GM-CSF, which is increasing granulocytes. We'll talk about that more when we talk about drugs that affect blood cell development. So that's red and white cell kinetics. And then we'll go on to some of the disorders that we've been hinting at so far. We could have an anemia, which is when we don't have enough red blood cells normally. And when that happens, we're going to need to kick up our red blood cell production because we don't have enough for some reason. And so the body, in trying to make as many red blood cells as possible, will end up pushing those blood cells out earlier than they're normally ready to. Sort of like how in COVID, a lot of the nursing and medical students had to do some of the work more than they were ready to. Actually, I'm not sure if that's the case. I don't think some people did. Yeah, anyway. I don't think that's the case. That should have anyway. The point is that it pushes out these red blood cells before they're ready. So then you get these these reticulocytes, which are just they just turned 18 and they got kicked out of the house. But they're clearly still kids, sort of. That's what a reticulocyte is. And if you do have a lot of reticulocytes, that's a sign that you're making blood cells. And so that's a good thing, at least, right? If you're not seeing a lot of reticulocytes, that means your body's not compensating for that low red blood cell count, which could be a signal that your marrow is probably effed up for some reason, right? And the size of the cell will tell you something about it as well if you have an anemia. If you have if the cells are smaller than normal, microcytic, that probably means either you don't have enough iron or hemoglobin. So either you don't have enough iron, or not enough of that iron is being used to make hemoglobin, or you have lead poisoning. And most commonly, I think in the United States, it's less about that. And if you have microcytic, it's probably either genetic or probably lead poisoning. And if they're big, that means that there is a problem in your red blood cell blasts becoming mature red blood cells. They're not dividing properly, right? So that can be a cause of some problem in making DNA. So we can talk about folate and B12. Or it could be some sort of liver disease as well. If they're normal, that just means that maybe they're dying early for some reason. Who knows? But it's not a DNA problem. It's not any of these. There's also some special kinds of anemia where the cells will look weird. You'll have sickle where they just sort of collapse, and we'll talk about sickle cell as well later. Schistocytes is when they're sheared and sort of broken up. You could have a leukemia, not of white cells, but I think leukemia can cause you to have anemias. Yeah, you can have different looks. And we'll go into a lot of different red blood cell looks later on. You can also have marrow failure, as we were talking about earlier, when we don't have a lot of reticulocytes. The marrow is just not doing its job at compensating. And that can either be because our blasts are dead. Why? That could be aplasia, right? Pure red cell aplasia. Let's take a look at pure red cell aplasia, because I'm not familiar enough with pure red cell aplasia. Oh, I did that right. Oh no, I should look at the... Let's look at the slides for aplasia. If it'll load, that is. Wow. You are really not being my friend today. Yeah, here we go. Pure red cell aplasia. So this is when we actually have direct problems with the erythroid progenitors. Or we're purely just not making enough, is what it is. Okay. And that can be due to an infection, like parvovirus, or it could be a thymic problem. Why that is the case, I'm not actually sure. Let's find out. So these are all actually pure red cell aplasias that we're talking about here with the thymus. So why thymoma though, right? Cause red cell aplasia, sorry. Oh, okay, understood. Understood. Yes. Okay, a thymic lesion. Okay, understood. So that would be more of a autoimmune problem right here. Right? Where either we have an infection of the bone marrow, which kills our blasts, or we have some sort of immune T cell development issue where our T cells will go in and our T cells will kill our blasts. So that's what causes the pure red cell aplasia. Aplasia meaning not enough, right? Not enough development, as opposed to hyperplasia. Okay. We could also happen due to chronic disease and inflammation, which eventually might reach the marrow, kill our blasts. All right. So cell-mediated. This is like other mediated, other autoimmune mediated, infection mediated, right? And it could also be because of renal failure, as we were talking about earlier. Not enough erythropoietin will lower our blasts. Yes. What's our liver erythroid hyperplasia? I don't actually know what that's referring to. Some of these things I really don't know. Maybe in the future it'll be better for me. I'm just going to go through. And if I have something I don't know, I'm going to mark it and come back to it at the end. That way, it's a little bit more smooth. Christian has recruited me to go play tomorrow. I will fulfill my duty and defend the family honor by winning our IM game for volleyball. Let's see. Here we are again, trying to figure out what they meant by erythroid hyperplasia. While that's loading, I'm going to go down to a bigger problem. If it's not your erythroblasts that are being destroyed, it could be your precursors that are getting destroyed, which could be a stem cell issue or a lack of stem cells. You could have fibrosis and destruction at the marrow because of a tumor, or you could have aplastic anemia, which just could be damage to these stem cells. Yeah, just fully just destroying. Aplastic meaning failure. Yeah, okay. We wanted to look at liver erythroid. Hypoplasia. I wrote hyperplasia. That's not right. Okay. Why did I say liver? This is just confusing, isn't it? Alright, it looks like it's only in his notes. Only in his slides. There's just not enough in the liver, as opposed to not enough development. Right. I mean, it's what you would expect, right? You would have low erythrocytes, and you would have a lot of it's essentially a sign that you have all the other myeloid cells. But something is specifically wrong with your erythroblast. Okay. Took a while, but yeah, that's what we're talking about right here. We've already talked about problems with the big precursor. We cause pancytopenia, which would cause all our blood cells to get messed up. And we can also talk about polycythemia, which is what happens when we have a lot of red blood cells. That could either be due to benign conditions, either we're dehydrated and it just looks like we have polycythemia, or it could be something where we actually have increased erythropoietin, we actually have more red blood cells. Or we could have primary polycythemia and actual malignancy, which we will cover as well. So that's our kinetics. Took me a while to figure out this hypoplasia part, but everything else is right. Okay, still 30 minutes. 30 minutes each. It's going to take me a while, bro. 24 hours. That's if I only do this. We'll see if I can get a little faster. Alright, so we're done with our core part of hematology, immunology. So we're going to run and move on and talk about our platelets. Let's talk about platelets. Yeah. Platelets. So let's talk about coagulation first. I'm going to also open it in case we want to look at any of the photos on hemostasis. So, there are 3 steps to hemostasis when we have a bleed. So, first, the first instinct of our body is to vasoconstrict and tighten those blood vessels so we don't lose quite as much blood, and that's mediated by our nitric oxide, PGI2, endothelin, but these are all involved, but not all of these vasoconstrict actually. So I made that a little bit confusing. As you can see here, PGI2 and nitric oxide are normally involved in preventing vasoconstriction, right? But when we have damage, it will decrease PGI2 and nitric oxide, PGI2 being prostaglandin I2, which these are both anti-clotting factors. So when you remove these, you have a more pro-clotting environment, right? And endothelin the role of endothelin is to constrict, yeah. Okay. So these two you have less of, which causes constriction. This one you have more of, which causes also vasoconstriction. I'm going to add arrows for those later. So that's our first step. And then after that, we start to talk about clotting. So first we have to have our platelets arrive on the site, and that's our primary hemostasis. And so in order for our platelets to do the job, first they have to get there, and they have to stick there. So that process is called adhesion, right? and they connect with these anchors called von Willebrand's factors. Talk about the platelets. You can find a picture. So here's a raw surface that we're talking about. The raw surface will have exposed von Willebrand factor, which the platelets will then grab onto right here. And they use GP1B in order to attach onto von Willebrand factor. If they fail to attach, or if there's no anchor point, then adhesion is going to fail. Right. So either the anchor is missing, the anchor on if the platelet is our boat, and GP1B is our anchor, the anchor has to anchor to something, right? Because the anchors have the two. I'm really going into this analogy, but anchor has these two sharp points, right? It's not just a heavy weight. No, it also has to latch onto something. Otherwise, it's not quite as effective as an anchor. So without that surface to anchor onto, we have nothing. So those we'll all talk about these in our bleeding disorders as well. So then after that, the platelets have already attached. Then we have activation, where they're going to puff up, and he called it sea urchining. But what actually is happening is they're releasing a lot of the factors that we were talking about in our platelets talk a little bit earlier during the formed elements. This is when we're going to talk a little bit about the granulomeres, and we're going to talk about these over here. So anyway, they're first going to sea urchin out, and then we're going to talk about aggregation is when it's actually over here. Secretion, so ADP, thromboxane, A2, these are from the delta granulomere being released out here. And so thromboxane is a prostaglandin that helps clotting. ADP is also important here as well. Which is just a pro-clotting factor for platelets. So then after that, this is going to attract more platelets to come and make it more likely for other platelets to attach onto our existing platelets. So that's when we call aggregation, right? After adhesion. I would even call this maybe cohesion, right? Adhesion versus cohesion. But they'll just attach to each other like building blocks, like Legos. And so what they need in order to do that is they need fibrinogen. Fibrinogen, which is our baton, right? And then we need our anchors, our little hands, which is GP2B. So I guess how I would describe this is, in really conservative China, people used to hold hands, but they can't hold hands directly in public because that's scandalous. So instead what you do is you both hold onto the same stick. So fibrinogen is our stick. Fibrinogen, which is also carried inside of the granulomere, alpha granulomere. Anyway, is the stick, and then they use the cute little GP2B hands, and they each hold on, and they just hold hands like that, one after another. And that's going to make a big clot when you get more and more and more of those, right? And there are some ways you can assess this. You can use platelet count. Bleeding time is he talked about as kind of an antiquated method where you actually cut the patient, which is kind of not fun. And there's also platelet aggregation studies, which are a little bit more specialized, but they'll actually involve these right here. This is actually pretty important. Where they're going to take the plasma and the platelets, they add different clotting factors in there, and then they see whether it worked or not. Right? So under normal circumstances, all of these are pro-clotting factors, ADP included, epinephrine included. But depending on which one of these pieces over here you're missing, you're going to get a different look on the platelet aggregation study. I will be talking about this a little bit more when we talk about bleeding disorders, which is coming up. And there's also inhibition of coagulation. So we'll talk about coagulation next. So we already talked about platelets, right, which arrive on the scene and start to hold hands and anchor themselves. And then the coagulation cascade comes around and glues everything together. And this is done through coagulation factors, which are these circulating molecules. There's 3 paths to coagulation, or there's 2 paths that come together and form that common path. My diagram's not as good as his, so we can just show his real quick. He has a simplified diagram as well, so we're going to use that one. So the intrinsic pathway, which is caused by tissue factor, also known as factor 7, will directly activate the common pathway, which is 10, 2, 1, and then 13, versus the intrinsic pathway, which starts with 12, factor 12, and goes towards from 12 to 9, 12 to 11, 9 to 10, 12, 11, 10, 9, and then this is 7. 8 and 5 are also involved over here as well, so I've written them in. But these two are technically activated by different things, but they will happen at the same time in real life. So it's hard to sort of remember this. The way that he taught us is the intrinsic is the 10 intrinsic, meaning you'll have 10, 12, 11, 9, and 10. 12, 11, 10, 12, 11, 9, and 10, right? And also 8, kind of, but he didn't include that. We'll call it your intrinsic path, and then the extrinsic path will include 7. It's our tissue factor. And so that'll all come together. And then you'll have the common pathway, which starts with 10, 2, 1. 1 is fibrin, which is essentially the same thing as fibrinogen. It's just the finished form of fibrinogen, which is this little hand-holdy guy right here. So you have a lot of fibrinogen going on, and then 13 will finish everything off. So coagulation cascade will sort of finish off the clotting that was started by the platelets. I guess you'll have a lot more fibrin sticks going around, so people can hold hands more easily. So scandalous, hold hands with a lot of people, but you know, I guess that's where the analogy dies. And there's a few different ways you can inhibit that coagulation, and we'll talk about that as well. There's inhibitors for that. There's antithrombin, which acts specifically on certain parts. We'll talk about this more in the next couple talks about clotting. But plasmin and plasminogen are very interesting as well because they're involved in lysis. So this is after everything is done and we have a finished clot. You could still break that clot using plasmin and plasminogen. So how do we tell if a patient's not clotting well? We can talk about prothrombin time. Prothrombin time is actually just testing your extrinsic path. So you add tissue factor. You add tissue factor, and then you see how the clotting goes. You add this guy, right? You can also do activated partial thromboplastic time, which is when you do 12, which is intrinsic. So APTT. And then there's also thrombin time, which is directly right here, which is common pathway. You're just testing right here. So those are your three tests right here. Extrinsic is prothrombin. Thrombin is common. That's easy. And then intrinsic is activated partial thromboplastic. Kind of complicated name, but that's the basics to clotting. So then we're going to go in a minute and go on to the problems that you can get when you have bad clotting or too much clotting. Okay, now we're talking about coagulation problems when we have too much coagulation, called hypercoagulability. And the thing about too much clotting and or clotting in general, clotting problems in general, is that there's a few different possible reasons. This is something we call Virchow's triangle, and these are like the three big reasons that you can start clotting. It can be damage to your arteries, right? Or it could be, which is normal, honestly, right? But you could have a lot of damage, which would cause a lot of clotting. You could have a problem where your blood is not moving as much as it should be, and then that will increase as we were talking about earlier. Let me actually bring that up. It'll tip the balance more towards thromboxane and less on your PGI2 and nitric oxide. When you have a lot of platelets together, you're going to have a lot of thromboxane, and that's going to favor clotting. Where is that? Right, okay. So circulatory stasis. But then the one that we're going to focus on out of these three is hypercoagulability, which is more inherent problem with either your platelets or your clotting factors. Okay, so this can either be inherited or it can be acquired, as are most diseases. Let's talk first about inherited. And while I'm at it, actually, let me bring up this guy right here as well. Okay. Yeah. So it could be factor V Leiden. So factor V Leiden is an inherited sort of trait that doesn't normally cause hypercoagulability. The main thing with factor V Leiden is that when you put anticoagulants in, they don't respond as easily. And that's what we call protein C resistance. Right. So protein C and protein S are both involved in breaking down factor 8 and factor 5. So if we see here factor 8 right here and factor 5, which is I'm losing track. Factor 8 and factor 5 right here, both of these guys that are involved in the intrinsic / common pathway. I guess common more importantly, but they will decrease that clotting. Protein S they're glycoproteins. Oh, I forgot to touch on the vitamin K. Let me go back and do that real quick. The other thing about coagulation cascade is that vitamin K is very important in activating. If I understand correctly, it's very important in activating the coagulation. So not in making coagulation factors, but it's important in their action, almost like a cofactor sort of relationship. And so the ones that need vitamin K are 9, 10, 7, and 2. So if we look here, that's 9 from the intrinsic pathway, 10 and 7. So the bulk of our at the branch point, all three of these are affected. 9, 10, 7. And then 2 is also affected, and 2 is very important, right? Our thrombin, which is right next to our clot. So, vitamin K. Let's go back to our bleeding disorders right here. Our clotting disorders. So, protein C and protein S are actually involved in the sense that they're supposed to decrease factor 8 and 5 clotting. Supposed to decrease our intrinsic / common, but when you don't have enough, what happens is you get more clotting. These are If I remember correctly, these are just uh, normal glycoproteins floating around. So without them, you're more prone to clotting. And what happens in warfarin? Actually, I have to pull that up. Right, as we were talking about. Okay, yeah, that's the reason I went back and talked about vitamin K. So, protein C and S are actually really important in blocking clotting, right? But they also depend on vitamin K. So, what happens is when you have something like warfarin, it will drop your coagulation, right? But even more importantly, it's going to drop protein C and S even more. Right? So it'll drop the others a little, but protein C and S disastrously. So then you'll ultimately have an overall tendency to have coagulation and clotting. So that's what that is. Which can cause purpura fulminans, which is skin necrosis, so thrombosis throughout your skin. And it can also cause really bad skin necrosis as well when you have clotting going on all over your skin. It's called hypoxia and clotting and death. That's what that's going to cause. Another inherited problem is if you have low antithrombin. Antithrombin is going to affect even more clotting factors, if I can bring it up. We can bring that up right here. Oh, this is everything right here. Yeah, so antithrombin is going to touch on everything on this path. So it's like protein C and protein S, but it's everything intrinsic and common. And so that's 2, 10, as we would expect, right? And then our 9 and 11. 9 and 11. Yeah. And that causes deep vein thrombosis. So not as much skin stuff going on. We're getting big clots happening in our legs instead. And then we could also have something called prothrombin 2210. Where we just have more prothrombin. It's a mutation. And you'll have a lot of prothrombin. And so the way to do that is we'll do plasma exchange with somebody who has normal thrombin levels, and then they won't clot as easy. So if we were to sum up all the inherited conditions, right, we have these are all intrinsic and common. And then this one is just common, prothrombin, because it's really down the ladder. And so actually for protein C and protein S deficiency, you could give protein C, I believe. Right, you could probably try and give more of that, but if there's a factor V Leiden problem, then you won't be able to achieve that as easily. So that's like the relation between those two. It's not as treatable. Whereas for these ones, you can't really give them protein C. That's not going to fix it. Instead, you're just going to have to switch out the plasma. I think that covers inherited. It's a little bit challenging, but I think it makes some sense, right? I'm going to go on right now to acquired reasons you'll have hypercoagulability. You could have a lot of heparin. What heparin does is it I think what happens is factor 4 ends up getting. Let's actually look about that. I don't remember. So platelet factor 4, which we are looking at here, factor 4, where are you, factor 4? Okay. I don't think we learned about a factor 4 as much. But not enough heparin. Oh, okay. So what happens is you'll have antibodies against the factor 4 heparin complex, which will end up activating the platelet. So I think what happens is it prevents it from breaking apart. So it takes a normal clotting mechanism, which is platelet factor 4 binding with heparin. When you give them the drug, right, it should gotcha. You give heparin to patients, because it's an anticoagulant, but then if they have an antibody that's very specific, then what's going to happen is that complex is actually going to promote coagulation instead. Somehow. I'm not entirely sure how. I'm not entirely sure what's going on. Platelet factor 4 binds heparin. Heparin is an anticoagulant. So we need to understand platelet factor 4 a little better. Heparin's supposed to make them bleed less. Sorry, it's supposed to make them clot less. But But instead, if they have this antibody, sorry, this is quite complicated. I guess you'll probably, it'll be like yeah. So what'll happen is you'll give the patient an anticoagulant heparin, but instead of seeing them clot less, you'll see them clot more because they have this antibody associated with heparin. The importance of platelet factor 4 is not as important, I think. He talks about how factor 4 promotes coagulation, which I'm not entirely sure about. But I think what we do need to know is that it's a complex between heparin and something else that will cause clotting. Biggest takeaway, anticoagulant becomes a clotting agent. That's what that is. Thrombotic thrombocytic purpura. All right. What happens is the von Willebrand's factor is normally present, and it's normally cleaved by this one right here. I don't know if I'm spelling that right. Let's see. Is this on his notes? Should be. Yes, here it is. So normally this protein cleaves von Willebrand factor. But if you have not enough of this Adams 13, maybe because of an autoantibody towards that, your platelets are going to get attracted to this long von Willebrand's factor. I guess they're more interested. There's more places to bind for von Willebrand's. So that will cause your clotting. So the definition of purpura, I believe, is when it's on the skin. It's leakage at the skin. So it's like bruising. It's a form of bruising. So yes, not enough Adams 13, long von Willebrand's factor, and your platelets going crazy, clotting it, and you're going to have a lot of skin-related clotting, but also throughout the body. Pretty scary stuff. A lot of this is going to affect your brain too. Like that one has stroke. This one has neurologic findings. Not great. But at least this one is curable if you stop the drug. Then it will be okay. All right. Another one can be related. It will be called the disseminated intravascular coagulation. And so this is caused by a cytokine storm when you just have a lot of antibody, a lot of other pro-clotting factors, inflammatory factors running around. It's going to cause your blood to clot. And that happened in COVID. And it can be caused by a lot of things. trauma, sepsis, malignancy, OB complication. And what this clotting looks like, it actually looks like a net, is what we were told. And it can shear red blood cells as well. So if you see red blood cell shearing, that is also a sign of the disseminated intravascular coagulation. In some ways, I want to say that heparin-induced and disseminated are a little bit similar in the sense that they both involve antibodies and a sort of pro-inflammatory environment that causes clotting. Whereas the thrombocytic purpura, that's a very specific, very unique case. So malignancy related to the DIC, but malignancy can cause hypocoagulability even without this specific kind of coagulation. So then we look for Trousseau's sign. See a photo. Trousseau right here. It's sort of bruising going on as well. Let's see if we can compare it to purpura, bocytic purpura. Okay. So purpura is a lot smaller. You see all these little guys. Oh, that's a lot. The little dots. Close to petechia. Yeah, that's what they were saying. We could get bigger though, right? Trousseau sign. It's similar, but I want to say it's more diffuse. It's more like bigger, sort of bleeds, caused by clotting in these skin vessels. Once again, can be related to adenocarcinoma. And this was the shearing schistocytes as well we're talking about for DIC. His acronym is MOST. Malignancy, OB, sepsis, trauma. Cause of cytokine storms. Most signs of cytokine storms. Okay, that's good. Most right there. You could also have antiphospholipid syndrome. And what that is, it's just a pure autoimmune problem. So you just have a ton of autoantibodies binding to your endothelium and causing thrombosis. So I want to say almost all of these are inflammatory. The only one that's not inflammatory is the thrombotic thrombocytopenic purpura. That's the only one that's very specific. Everything else is all related to antibodies and autoimmunity. The reason he was talking about artificial APTT right here, and if we remember correctly, APTT is a test of the intrinsic clotting system. It will look like the person has prolonged clotting. But the reason for that is because the starter is supposed to be phospholipid. So when you have the antibodies, what they're going to do is they're going to bind up all the phospholipid and prevent it from starting the clotting test. Right? So then it will look like it's actually higher. But then if you add a lot more phospholipids so that the phospholipid starter isn't covered, then it will get your normal APTT. So that's what the artifact APTT is. It just so happens that the starter is covered by this. But in the body, I suppose that's not the case. It's just a difference between the body and the lab conditions. You know, where in the body having this antibody will cause clotting, whereas in the lab it will artificially go against your assay a little bit. So that's what that is. All right. Hypercoagulability. I'm slower than I thought. Okay, great. So now we're going to go on to bleeding disorders. Let's go on to bleeding disorders. Okay. And let's pull up a picture of our awesome little thing right here. We didn't talk about TFPI as much, but there are a number of coagulation factor inhibitors. Did we? I don't think we talked about the... Oh yeah, that's right here. Okay, I clicked on the wrong one. Maybe I should have done this first. Just like he did. But, okay, bleeding disorders, when you have a failure to clot. And we talked about a number of these earlier. In his image. So we can conjure from memory, but we can also take a look at his pictures. But essentially any part of the process from the vasoconstriction, vasoconstriction not as important, but any part of the process including that initial platelet aggregation, cohesion, activation, anything there, or anything involved in your clotting factors is going to cause a problem in your... And let's take a look right here. I think he had a picture that shows us the problems associated. Oof. Oh, I forgot to talk about... Oh, no. I haven't talked about it yet. We're good, we're good. He had a photo of all the diseases. Here we are. Okay. Yeah. Okay. So, anything involved in the process of clotting whether it's your primary clotting, adhesion, activation, aggregation, or it's your secondary clotting, coagulation cascade, you're going to have a major issue, and you're going to have a bleeding disorder. Right? So, let's talk about it. We could have a vessel failure, which could just cause bleeding, just mechanically damaging your vessels, which is kind of analogous to our vessel problems here. Failure to vasoconstrict, failure to maintain integrity, right? Whether it's vasculitis, scurvy, corticosteroids, something that is preventing your blood cells from being strong and clotting themselves and vasoconstricting, vessel failure. And then we'll talk about platelet failure, analogous to our primary, right, platelet problem. And those are known for having your smaller bleeds, shallower bleeds, either nosebleeds, gum bleeds, as the photos were showing. And that could be a problem with a few different things. So all of these here, depending on whether you have enough platelets, whether the platelets can get to where they need to be, right? Or whether the platelets are going to do what they need to do. So you're going to have a problem with production if you have a marrow failure, as is expected, right? Not enough platelets. Can't clot. Or you don't have enough vitamin B12, which is going to affect our blasts. It could be shortened circulation. We could have a problem with our spleen or maybe our liver, where the maybe the platelets get phagocytosed. Maybe they get stuck, right? And if they're not getting where they need to be, then we don't have as many of them to clot with. We could also have immune thrombocytopenic purpura, which is antibodies against parts of our platelets. So that's a little bit more related to what I was talking about earlier, where you'll get antibodies to that, and then it'll probably get phagocytosed, right? Your platelets will get recognized for some reason and get taken out of circulation. What does immune thrombocytopenic purpura look like? Probably very similar, right, to what we were talking about earlier. It's the same purpura, except in this case it's a bleeding problem and it's not a clotting problem, right? Instead of having too many clots, we're not having enough. Actually, I believe this is a clotting problem as well. If we see a diagram here. Oops. Not enough platelets. Yeah. Although I would imagine that this kind of presentation would occur in other cases of platelet deficiency, of thrombocytopenia, but apparently it's more associated with these autoantibodies. Which leads me to believe that maybe that means some of the platelets are getting used up, causing maybe surface clots once in a while. I'm not sure about that. You know, because the antibodies themselves could be pro-clotting, whereas overall you have fewer platelets. Let's take a look. he didn't focus as much in his slides on this.
Hi, Kevin.
Hey Google, stop. It looks like there's just antibodies to platelets. So I suppose you'll end up seeing your body cells phagocytose platelets. Okay. It could also be poor function, which is the main part of what we've been thinking about so far. If we can get that nice diagram up again right here. Right. So the first part of it is our von Willebrand's factor needs to be there. You need to have some anchor point. So von Willebrand's disease is you don't have that. And so then you'll have nothing to cling on to. And these platelets will never be able to attach. And this could be a result of a number of things. You could have fewer von Willebrands. You could have missing multimers of von Willebrands, so it'll be a dysfunctional von Willebrands. And what that looks like is this. So if this is normal, then you're missing some of your subunits. So type 1 is if you have less of everything, so you just have fewer. Type 2 right here, and type 2A and 2B are different kinds of missing multimers. So you can see completely missing on this Western. Or complete absence, right? You have nothing here. I guess it's control down here. And so those are the kinds of von Willebrand's. I want to say von Willebrand's deficiency, right? Is what it should be. Could be deficiency, could be dysfunction. And there's an issue because factor 8. This is actually interesting. Factor 8 is important at bringing von Willebrand's to this this raw surface. So what I want to know actually is von Willebrand's ever soluble? How does von Willebrand's carry factor 8? So I always assume factor 8 is circulating in the blood, right? Whereas von Willebrand's is stuck to the end. So let's see. I think what we were taught is that it's in the blood, which is kind of confusing. I don't think it's really in the blood, right? Because if it was in the blood, it would start clotting. Huh. It looks like von Willebrand's is also in the plasma. Huh. I don't know why, if von Willebrand's factor is in the blood, why it won't just cause coagulation. That is confusing to me. But what we do know from this is that von Willebrand's factor is somewhat circulating, and so is factor 8. And if you don't have enough von Willebrands, then factor 8 gets degraded. And then what happens is that you have a bleeding problem from low factor 8, right? So not only does it look like you have a platelet failure, but it will also have a clotting failure because you don't have that factor 8. So this kind of von Willebrand's disease is sort of a two-hit. You get messed up for both reasons. All right. Next is Bernard-Solier. That's if you don't have the anchor. There's no anchor point, right, for von Willebrand's. And then Bernard-Solier is you don't have an anchor at all. So then your platelets are just not going to be able to attach to the existing von Willebrand's. We're going to go into this ristocetin in a little bit. And then Glanzmann thrombasthemia is when your platelets are doing this first step, but they don't hold hands with each other. They're not very nice to each other. You don't have enough of this GP2B, right? So, attachment point's gone, anchor is gone, no friends. Glanzmann has no friends. Bernard-Solier is a wanderer, right? And von Willebrand's is, God, yeah. So that's why he has two names, Bernard and Solier, because he just goes around to different places. People know him. That's how I'm going to remember this, right? The man with two names versus the man with, or man or woman, I don't know, who has no friends. So those are these. Glanzmann, Bernard-Solier, von Willebrand's. Those are our three big guys. Renal failure can also get involved in this, I think. I don't think people know why. But, it's either because there's increased nitric oxide, or it's because the red blood cells are smaller. And less red blood cells mass means less platelets being pushed out to the periphery, which means less contact with the surface of the endothelium, which means less clotting. I didn't go into treatments for a lot of these, I realized. But a lot of these can be done with platelet transfusions, right? For these platelet related ones. Alright, let's take a look at this right here. So this is pretty important. So we take our plasma and then we add a factor that should start clotting. And normally all of these are pro-clotting. With von Willebrand's, ristocetin does not cause it. So how does that work, right? In what is this called? A clotting platelet aggregation study. How does that work? That's what I wanted to know for a while. So what does ristocetin do? Okay, but how? Unknown fashion. Okay. It's an unknown mechanism, but ristocetin, okay. As we can see here, ristocetin, it is an antibiotic and it promotes somehow the anchoring of your what's it, GP1B? Yeah, GP1B to von Willebrand's factor. That's its job. That's the effect. So when you add ristocetin, it should normally cause clotting, right? But since you're missing one of these two, nothing happens, right? But why do we see this result in Glanzmann thrombocythemia? That's the question. Glanzmann is when your platelets are unable to bind to each other. What I'm taking from all of this is that all of these other curves are involved in aggregation and not in adhesion. Right. So if we were to look at this, right, adhesion right here, von Willebrand's to GP1B. So this is what ristocetin is involved in, adhesion. Activation is separate. And then aggregation is when we have ADP, thromboxane. We have the serotonin that's not written in here. But it appears to me that all of these other ones are meant to increase your GP2B interactions with your fibrinogen. Right, your GP2B with fibrinogen. But your aggregation. So it stands to reason that if you have Glanzmann thrombocythemia, right, you can't make friends. And these are all friend promoted, like friendly chemicals, right? So no amount of friendliness is going to help your loner frickin' platelet. However, somehow ristocetin works. I really don't understand why ristocetin works. I mean, it makes sense that you have a starting clot, you know? Ristocetin will help you start off. You have GP1B. Adhesion is working in Glanzmann thrombocythemia. But then aggregation is just not as good. So it's possible you do have your adhesion, right? But then your coagulation is able to finish the rest, even without good aggregation. So let's go back here. So this one has no adhesion. That's not right either. Maybe the way that it works is that ristocetin works through adhesion, right? So if adhesion doesn't work, ristocetin doesn't work. But Glanzmann has normal adhesion. It has abnormal aggregation, but it has normal adhesion. So it will clot. Right there. Right. Meanwhile, these ones over here cause clotting by favoring aggregation. So you could have even a small amount of adhesion. Even a small amount of adhesion on the surface, and it will still cause you to clot. So that's what all of these are. Right. In any case, it's all very confusing. But essentially, this is risdipine is a test of adhesion. That's all we can really say. Risdipine is a test of adhesion, and these are all tests of aggregation. That's the best way to explain what we're seeing here. All right, that's actually pretty complicated, but it's pretty likely that we'll see this little guy and probably this little guy here. So, we do what we have to do. Yeah. So then after platelets, right? So the problem with platelet failures, you have bad platelets. So if we gave you good platelets, you should be able to clot fine, right? Whereas clotting factor failure, we could give you good platelets, but that wouldn't fix the problem. Moreover, your platelets don't hold very well. Your clots don't hold very well. So you have deeper bleeds, more dangerous bleeds even. And so this can be acquired. I'll start there. You could have inhibitors of coagulation. So we can talk about these in a little bit as well. Hemophilia, von Willebrand's disease, right? As we were talking about here, complete absence of von Willebrand's will cause low factor VIII, which will cause a failure here to have coagulation factors. And this can be fixed with factor concentrate. Most of these can be fixed with some sort of factor concentrate. Inherited clotting failures, we can talk about factor VIII deficiency, which can be, oh, sorry, not 8, 13 deficiency. So this is a really rare one, is what the professor is talking about, where we're unable to do the finishing touches to our clot. Where everything's here, fibrin's here, the clot is made, but then the cross-linking is a little weak. So I don't think you get really bad problems through this. It's just your clots are a little weaker, a little wimpier. It's just not going to kill you, but yeah. And then our big clotting factor problems are related in hemophilia. If you have less than 1% clotting factors than the normal person, that's considered very severe. Your risk of dying is pretty high, so that's why that's there. But there's 3 types of hemophilia that we're talking about. A, B, C. A is low factor VIII. So that's why hemophilia A, once again, looks a little bit like type 3, complete absence, von Willebrand's disease. I would assume that type 2 von Willebrand's, you still have some factor VIII. But complete absence causes quick degradation of factor VIII, which is intrinsic pathway, right, as we were learning, which causes your bleeding. Hemophilia B is when you have low factor IX, which is closely related on that list. If we can bring up the picture again. I should just save that image. But you're going to have to take my word for it. Factor IX is intrinsic pathway. And, yeah. And then C is factor 11, also intrinsic, higher on the ladder. So intrinsic, and intrinsic. All intrinsic. I'm pretty confident. We can confirm that. Clotting. Intrinsic. So that's intrinsic. 8, 9, and 11. Right? Oh, I also had it here. I'm stupid. 8, 9, 11. 8, 9, 11. Yeah. All intrinsic. All the hemophilias appear to be intrinsic. And more importantly, we can also check the vitamin K for these. So 9 is the only one here, but number 9 is also related to hemophilia B. It might look a little bit similar. So hemophilia B might look a little bit like a vitamin D deficiency. Vitamin K, sorry. Whereas hemophilia A might look similar to, again, type 3 von Willebrand's. So that's bleeding disorders. That's bleeding disorders. I am doing okay for time. I did that in like 20 some minutes. So let's pull up our big map again. And yeah, pin tab. So our big map, once again. So we just finished looking at our basic ones and our platelets. And we have a long ways to go, but next we're going to go look at red blood cells. So I'll be right back. Alrighty. Let's check if this is still working. I hear my voice again. Let's check if this is still working. Hear my voice again. Yes, sir. Alrighty. I do not actually enjoy the sound of my own voice, especially not recorded. But it's making me feel like I'm building something. Alright. So we just finished this and platelets, 5 lectures, and that's a tenth. Tenth of everything in 2 hours, 20 hours to finish everything. Maybe 21 hours. Wow, that's a lot. Okay, let's go on to erythrocytes. Let's do the blood cell measurements first. Go number 5. So there's a number of red cell tests. Other than just looking for those reticulocytes or counting red blood cells, there's a number of things that we can do. So we can look at the erythrocyte sedimentation rate, which is a measure of inflammation. And so what we'll see in that is stacking. And how that actually works is normally your cells are quite negatively charged at the membrane, but there are certain inflammatory markers that are positively charged, and that will cause your red blood cells to stack more easily, resulting in a an elevation in it's essentially your red blood cells don't, it's more viscous. God, so complicated. ESR is just viscosity. Okay. And there's a number of reasons that might be. Fibrinogen, antibodies, other inflammatory markers, they all increase your ESR. That's I would say that's less of a red cell test, right? And more of just you're using red cells to measure something else, is what that is. Yeah. And anyway, we also have a reticulocyte count, as I was talking about a little earlier. What happens when you your marrow gets pushed to make more red blood cells in a short amount of time? You end up getting these 18-year-old reticulocytes getting kicked out of their mother's basement or home or whatever, and they get found in the blood. So you could have a lot of them, which could mean that your red blood cells are not doing well, right? Or it could mean that you're just having too few of these, which means that your bone marrow is not making enough, right? Not enough. Apparently, it's not a good thing to not have enough of these poor 18-year-olds on the street. So apparently, that's not a good thing either. God, Michael's distracting me. He says the link's not working. I really doubt that, but I'm just going to continue. You could also look at marrow production directly by taking a sample of the marrow. You can look at how many cells there are and compare the amount of precursors and blasts there are relative to the amount of fat. And the older you get, the lower this cellularity gets, and that's okay. But you need to see if there's a drastic difference. That could be a bad thing. You could also look at the myeloid to erythroid ratio. So this was talked about a little bit earlier. We were talking about the blood cell kinetics, right, and anemias. What that looks like is you're comparing the myeloid cells to the red blood cells. And so if you have a very high myeloid to erythroid ratio, that means your red blood cell blasts are probably messed up. Right here, you see that. And if you're having a lower, that could mean that either the monocyte and granulocyte lineage is suffering, or it means that something is going really bad with your progenitors other than your erythroid blast. You could also have antibodies. If you had a hemolytic anemia, especially immune, you could test for that. And so there's two tests here. There's Coombs indirect and direct. So what direct is essentially you take just the blood out of the body with the antibodies on the blood, whatever's attached. You don't change anything. And then you add a special factor that binds, I think it's for the FC region on antibodies, but it will cause agglutination if there's any antibody stuck on a red blood cell. So then if it agglutinates, that means your body is already doing some sort of hemolytic anemia. It's already happening, right? Indirect is when we take the blood of somebody else and we wash it and we make sure there's no antibodies on that blood. It's just normal blood. And then we add patient serum and we introduce possibly anti-red blood cell antibodies. And then we test. And so this is not a sign that we're already under attack. This is a prediction that an attack might happen if we give donor blood, if two kinds of bloods mix, right? So this is a good test to see if you have the hemolytic anemia of, this is hemolysis going on in a newborn, right? If you have a mother who is negative for a blood group that their child might be positive for. So that's what that is. And we can measure, of course, red blood cells directly. You could take the blood and count it, a number of red blood cells. Very classic. We could look at the hematocrit, which is volume by volume, comparing red blood cells to the total blood. So then this will tell you about anemia, and you can be sure of that. Whereas red blood cell count, I mean, it's possible that both of these, I guess. Red blood cell count is they're both affected if your patient's dehydrated, right? Because they'll affect the volume. But hematocrit is probably a little bit better at testing for if you have small blood cells, microcytic or megaloblastic. Is what that is. You could also do hemoglobin. You can just lyse them all and then just test for the protein, measure the protein. So that's also a good test if you have hemoglobinopathies. There's indices that you can look at. Red blood cell size, as I was saying, hematocrit, I guess, is okay. But if you really wanted to look at the blood cells size, you would do mean corpuscular volume, which I guess just means cell volume, right? The mean cell volume. And it'll tell you the size. And better than just doing hemoglobin, you could take this and I guess you compare hemoglobin with red blood cell count, and that gives you this. You take hematocrit and compare it to red blood cell count. That gives you mean corpuscular volume. That's your indices. Indices derived from primary measurements, right? So, mean corpuscular hemoglobin, you could find out hemoglobin per cell, whereas this is hemoglobin in general in a blood sample. You could also do the size of a red cell, right? Which would help you to determine a few things, including pore morphology, but it could also show you maybe high reticulocytes. So, all in all, summarize it. Red cells, you can count them. You can do averages per cell, right? And you could get size. You could find out if there are antibodies already or if there will be antibodies. You can find out marrow production. You can find out, these are both sort of production related. And you can also find about inflammatory markers. So that's that. Pretty simple. So now we're here. So next we're going to talk about we're probably going to talk about thalassemias and hemoglobinopathies. Yeah, we'll talk about those, especially because well, aerothalassemias. Oopsies. Thalassemias. Oops. Is that right? I suppose we'll talk about macro and microcytic first, and then we'll go into hemoglobinopathies. Yeah. Okay. Be right back. I got it.
The stream blows.
My first viewer. That's a milestone. I mean, it's not Pokemon stream, so I don't know what I'm competing with. Alrighty, going on anemias. Let's go, no. I want to do thalassemias first, I think. And hemoglobinopathies first. This one is both. We'll just cover them both at the same time. Okay. So, hemoglobinopathy. You have a problem with hemoglobin. If you have too little hemoglobin, that is thalassemia. I have no idea why it's called that. C. Okay, I guess the disease was present near the sea. Whereas hemoglobinopathy, that's more on the nose. So, okay, whatever. Disease near the sea, thalassemia.
Time is 4:45 p.m. Time to start wrapping up your workday and plan for dinner.
So there's two types of thalassemias that we talk about. And that's actually based a lot on the type of hemoglobin that we're talking about. So actually, before I talk about thalassemia, I should probably talk about the types of hemoglobin that exist. And I found out that my understanding of hemoglobin is not actually that great. So, it's a good opportunity to look at one of the responses that my professor gave me. So, normally, in all hemoglobins, I guess, hemoglobin, you require there's a few different type of subgroups, including alpha, beta, gamma, delta. And in an adult, we see hemoglobin A, which is alpha 2, beta 2. In a fetus, in a baby, little baby man, we have a different kind of hemoglobin. We have hemoglobin F. Okay, very promptly named. Adult, fetal, sure, which is alpha 2 delta, or gamma 2, sorry. So the alpha 2, beta 2, alpha 2, gamma 2. All right. That's hemoglobin A and F, normal. I guess I'll just go into hemoglobinopathies first after all. So there's a few different kinds of dysfunctional hemoglobin that can happen, right? One is you have mutation in the beta chain. God, let me mute that. Sticks and stones may break my bones, but okay. Anyway, so you could have a mutation in the beta chain. Here, let me see. Let's take a look at his. There's hemoglobin A2 as well, which is actually something that I failed to understand my first time through this. So let's find out about that. What? Oh, did he delete it? Oh my god, I think he deleted it. Let's see. No, it exists. See like A2, right? A2, A2, and F. I failed to understand that my first time through this. This is just objectives. He didn't have notes. Let's take a look at his slides. He goes into S immediately, but he didn't talk about A2. I can look it up, I suppose. That's why I don't understand it very well, but we can go into hemoglobin A2. Hemoglobin A2, which is A alpha 2 delta 2. So if we look over here, it's different. So A is beta 2, A2 is delta 2, which is also in adult, and fetal is gamma 2. Great. So if you have a defect in your beta chain, a very specific kind, then you get hemoglobin C instead. So you still alpha 2 beta 2, but it's a weird alpha 2 beta 2, which is hemoglobin C. I don't really know. Whoops. The rhomboid crystals, I suppose, is a problem with the hemoglobin that causes you have these sorts of abnormal findings. If these images will load, they look like that. And that's, as far as I can see, not as serious of a disease. There's also hemoglobin E, which he barely even focused on. I think he just didn't really care about it, right? So you can look into what hemoglobin E is. Is this another beta chain mutation? Okay. So all three of these are beta chain mutations. And when you have these beta chain mutations, it causes a variety of issues down here. Okay, let's start again. So, got a problem with your hemoglobin, either too low amounts or you have a mutation, and these mutations are almost always beta mutations as far as we're concerned for C, E, and S. So C, E, and S are variations of hemoglobin A, where the beta chain gets mutated. Whereas in thalassemias, you have a complete lack of either the alpha or the beta. So, beta is the source of almost all of our problems. Most of our problems. And hemoglobin E will also cause some problems. Milder hemolytic anemia, you have splenomegaly. So this one's not that bad. This one's a little worse. And then sickle cell is hemoglobin S, is probably is the most serious one out of these. And as a side note, all these are variations on hemoglobin A, right? Hemoglobin F is known to somewhat counteract the sickle cell disease, because it has better oxygen affinity, and we'll go into that in a little bit. But what is sickling, right? Sickling is what happens when our mutated hemoglobin A, which is now called hemoglobin S, it finds a way to polymerize and then turn into like a rod. Right? So in a very serious case, this polymerization happens all the time. In a less serious case, it'll happen when you have an insult. So if you're a heterozygote, then an infection might increase it. So anything that will decrease the O2 affinity of the hemoglobin S will cause it to polymerize more easily. And this can be caused by a variety of different triggers that can cause that polymerization. And then that's also why hemoglobin F is good, because it increases O2 affinity, so therefore it makes it less likely for you to have an environment that will cause polymerization. If you have enough of this sickling, enough of this polymerization, it will change the cell shape forever, which is called irreversible sickling. Repetitive polymerization. And this can cause a variety of problems. It can cause outright death of the cell. Right? Either immune related, where it can cause hemolysis either in the vessel or outside of the vessel. And that phagocytosis at the spleen can be compounded by these weird shaped blood cells, and you can have a spleen that's stuffed with red blood cells, which can cause infarct problem on its own, right? And spleen damage can also cause a lot of issues down the line for your red blood cells. Which it causes, like, I think it's the filtration on your red blood cells is not as good, so it lets some of these ugly guys get out, these Howell Jolly bodies. Let's see if I can pull up. That have DNA inside them. Yeah, that's that. It's like a cute little mark, but no, that's an ugly sucker. And in the process of having this destruction of these bad blood cells, your marrow could get overworked, right? And this, if you're having a lot of lysis in a short amount of time, which means either you have severe homozygous sickle cell, or you have heterozygous, but you got exposed to some really bad conditions all of a sudden, you could cause some pretty bad jaundice. A gallstone's more chronic, I suppose. Yeah, so a lot of free iron around there. As I was talking about in the liver, in the spleen, you could have the clogging of vessels, and this can happen at the penis and causing prolonged erection, and apparently the only way to fix that is to stick needles in it and give phenylephrine, which is pretty terrifying. And you could also have hypoxic infarct when you have low O2, because these blood cells are not as good as at providing oxygen, and they also don't move as well. So that failed O2 distribution can cause a lot of different issues. Problem with the eyes, blindness, renal damage, cardiac failure, liver damage, stroke, all of these things. Anything in the body, essentially, that's actively cellularly, it's going to be damaged by that. And this is a little bit more related to the iron overload, actually. If you have a lot of iron in your blood, that's going to cause a lot of infection to take hold, because you have that iron freely floating, when it should be very controlled, kept out away from all the bacteria. So you can have osteomyelitis, bone infections. You can have ulcers. So you should give somebody prophylaxis antibiotics for this. Yeah. So that's sickle cell. A lot of problems there. Sickle cell, I guess all of these hemoglobinopathies can be summed up as hemoglobin A gone haywire. Yeah. And then on the flip side of the coin, we could have normal hemoglobin. Each of these subgroups actually is made correctly, right? None of these subgroups are broken. However, some of them are missing. So alpha thalassemia is when you don't have alpha, and that will cause a lot of issues. You're going to get, depending on how bad that alpha is missing, you could get different things happen. I'm trying to remember, there are tetramers that are formed for each of these. Yes, okay, those are written up here. Sorry. So low alpha thalassemia. Low alpha thalassemia means you don't have alpha, which is important for all of these, right? All of these hemoglobins require alpha. So if you're missing that, which is a damage at chromosome 16, I don't know how I'm going to remember 16 like that, but sure, chromosome 16. You could have different variations on this in severity of how those genes are deleted. If it's only 1 or 2, it's minor, you know. You'll have a little bit of anemia going on, but it's not terrible. If you have maybe 3 of these genes deleted, it's pretty bad, right? And you're going to end up having a low enough alpha count where you'll end up forming, instead of hemoglobin A at low quantities, you'll start forming you'll start forming hemoglobin H, which is a tetramer of beta. So I can write this all out in a minute. And so that tetramer is a sign of some bad news, some bad splenomegaly, some systemic problems. And then if you have 4 out of 4 deleted, that's really bad. That means you don't have hardly any A, hardly any alpha hemoglobin A being formed. But the main reason that hydrops vitalis and hemoglobin H are different is because this hemoglobin H people normally survive past, or they can survive past their baby childhood. So then they have a chance at producing hemoglobin A. That's how you get beta tetramers, hemoglobin H. If you have a very serious 4 gene deletion, you don't even make it out of childhood. You don't make it out of the fetal stage, and that's why you'll never get a chance to see hemoglobin H. You'll only see Bart's hemoglobin, which is a tetramer of gamma, because you're trying to make hemoglobin F, but you failed, right? So then you'll have the gamma instead. Now that we're talking about this, I would imagine that hemoglobin H disease, you might also see some Barts when they're a baby, right? I would imagine you would. And then gradually as they get older, past 6 months, past 8 months, you'll see the H instead of the Barts. But they die. Bad hypoxia going to happen to them. I think the reason I wrote hemoglobin F, this is the question that I had for the professor right here. There's a rise in fetal hemoglobin in beta. Wait, what's up? Yeah. Okay. So the professor had a slide where he said that hemoglobin F is increased in alpha thalassemia, which is kind of confusing because you're missing quite a bit of alpha, which is needed for both A and F. But he essentially said the reason that's like a finding that you see. Maybe the F is favored over A or A2. But I think we should forget this HbF. Essentially, for alpha thalassemia, everything is dropped. It just so happens that it seems like hemoglobin A is dropped more for some reason. So that's that. So then beta thalassemia is when we are missing our beta. So as we've seen already, alpha is really important, but beta is, you can replace beta with quite a few things. You can replace beta with the gamma for hemoglobin F. You can also replace beta with delta for hemoglobin A2, right? So that's not as bad, I would say. Beta thalassemia is not as bad as alpha thalassemia, right? I think you would compare it to how do you say? Alpha thalassemia is like a person without a head, probably. Doesn't matter what you do, it's pretty bad. Beta thalassemia may be a person without a leg. You could get a prosthetic, but you can't get a prosthetic head. You can only get a prosthetic arm or leg or whatever else. So beta thalassemia, you can do some other stuff. And this is normally a result of some sort of promoter inhibition. whereas instead of a deletion, it's like a promoter thing. But again, there's 3 kinds of severity levels. And it's a little bit more granular than alpha. It's a little bit more variety going on because you can have partial inhibition as opposed to only full deletions over here. So there's this plus mild mark in the middle. Essentially what that means is you can have intermediate right here. So I guess the combinations for this, right? There's a total possibilities of only, how many is that? 6. There are 6 possibilities here, whereas there's 4 possibilities here for deletions. Doesn't matter. Point is, the most severe ones, if you have both of them are diseased, right? And at least one of them is severe, then you're going to get major. Whereas intermedia, either one of them is bad and one of them can make up for it, or both of them are just a little worse. But essentially what happens for that is you have overclocked hematopoiesis. Reason for that, I guess your hemoglobin is just worse overall, so your body has to compensate for crappy blood cells by making more of them, and that causes your splenomegaly, and it also causes your bones to change quite a bit. You end up getting these you end up getting blood formation really elevated at areas that normally don't make a lot of blood. So you'll see the marrow change quite significantly at these flat bones. And there's also talk of using hemoglobin F to improve the symptoms. So that's hemoglobinopathies and thalassemias, right? Thalassemias being beta mutations, hemoglobinopathies meaning beta mutations, and then thalassemias meaning complete lack. So I can write it all out right here too. So A2 is alpha delta, right? A is alpha beta. F is alpha gamma, right? And then alpha, and then the variations on beta is what causes your HBC, E, S, which are all plays on your classic hemoglobin A. That's what that is. Alright, thalassemia is done. It's been 3 hours now, and I'm done with this and these. 8 lectures. It's not bad. Better than 30 minutes. We're going to move on now to... Let's go on to megaloblastic and microcytic anemias. I'm going to start with microcytic anemias. Microcytic anemias. Okay. So microcytic anemias can be caused by a problem with hemoglobin, low hemoglobin. So essentially microcytic anemia is just you're missing heme is what it is. You're missing your heme. And so either that can come from your thalassemias when you have a missing and a lower amount of hemoglobin, right? Not hemoglobinopathy, because hemoglobinopathy would be crappy, but they'd still a lot of hemoglobin. A lot of hemoglobin, but still crappy hemoglobin, right? And it could be the heme formation, or it could be the iron that you're lacking that you need in order to make heme, right? So it could be iron deficiency, or it can be an iron to heme conversion process of creating heme. So let's start with the iron deficiencies. True iron deficiency is pretty rare in the United States, as the professor is saying, and because most people eat pretty good. It's possible in little babies if they don't switch to hard food and the mothers only give them milk and they don't switch over. It's pretty rare, but it happens. It could happen because you're using up your iron really quickly. You're growing really quickly, either in a growth spurt or a pregnancy or menstrual cycle, losing blood. That can also happen through cancers. So, yeah. You could be losing blood, pretty much. There's also, I guess that's the only big one for iron deficiency. I guess I can talk a little bit about formation of heme now. I can jump over from here to heme. It could be that your hemosiderin is your mitochondria not working, I guess, which doesn't allow you to create heme effectively. So you have enough iron, you just don't have good formation. So this can be caused by vitamin B6, copper, alcohol. So you have the iron, but you can't incorporate it effectively into a good heme. And that's why I have these ringed sideroblasts, rings of hemosiderin. Could also be lead. Which causes problems with forming that heme molecule in general. So then I'm going to come over here to the chronic diseases. What happens is, normally what happens is iron is kept at low concentrations in the body by a molecule called hepcidin. And when you have a lot of hepcidin happening during a chronic disease, your body is trying to keep this iron away from bacteria that can use it against you. And so a lot of IL-6 will cause high hepcidin, and it will cause you to not be able to use the iron that you have stored up. So functionally, it looks like iron deficiency, but in reality, it's just you're unable to spend it. It's like having your money locked up in something. Anyway. So treatment for iron, you could give oral iron, which often gives people diarrhea. You could also transfuse, which might be helpful, especially if you have an older patient or somebody who's at risk. We're also going to talk about transfusion reactions down the road as well. So there's some risk to transfusion, but sometimes that's worth it. Clinical signs of iron deficiency, pica. It's when you really want to eat some weird stuff. I was thinking about the One Piece character. He was talking about pica because he's a big stone guy, and eating clay is part of this pica. symptom. Lingual depapillation, really smooth tongue. Cholosis, you look a little like the Joker, and you got like your mouth is like splitting on the ends, kind of crazy. Plummer Vinson, which we've learned about, has the esophageal web, and you have these sores on your mouth. And then Koilonychia is these weird shaped fingernails. Let's see if you can get a photo. I think they scoop upwards. Yeah, they go upwards. I mean, that's like the really bad kind, right? But I mean, even this, yeah, this can happen. Huh. I actually know somebody who had fingernails like this for a while. Anyway, a lot of things happen with low iron. Yeah. We can talk about compartments for iron. So this one's pretty simple. So iron's mostly held by macrophages. So the storage iron is called ferritin and also called hemosiderin. These are the two forms of storage iron. And then there's also some iron in the blood held by transferrin. So that's what transferrin is. Essentially, if it's not transferrin and it's not hemoglobin, that means it's storage. Right? Labs. We could look at the blood. So we could literally check if the blood cells in the bone marrow are looking good and they have enough of this storage iron we were talking about. That's called the Prussian blue stain. We could look at the blood smears and look for any size changes, any pale looking red blood cells, so either not enough or so pretty much just not enough hemoglobin. We could also check the ferritin, right? So ferritin in the serum. So this is an indirect measure of storage iron. The direct is the bone marrow biopsy. And ferritin in liver disease is still pretty high for some reason. Why is that? I imagine this is a problem with the macrophages that are releasing the iron that they should be holding on to. Interesting. I don't really know why storage iron would be higher. I imagine it's because in liver disease you're having damage to the cells that normally store your I don't actually know. Why is ferritin normal? I already looked that up, but hopefully I can find something. Why though? Ferritin is induced in inflammation. But why? Oh, I understand now. As we were talking about hepcidin earlier, hepcidin sequesters your iron in the blood. But apparently ferritin can also be used during an infection to secure more iron. So with that ferritin, it will be increased. It will look normal because of that inflammation is causing increases. You could also do the iron binding capacity. And so that's like a comparison of how much transferrin is carrying iron. How much are you carrying? And I assume if it's far below, that means either that you have a deficiency or it could be the hepcidin that's causing that. Yeah, so that's because of hepcidin, because of this ferritin inflammation effect. That's why your biopsy is honestly the best. And then free erythrocyte protoporphyrin, that is a precursor, right, to hemoglobin. So if you have low iron, then you have a buildup of this precursor. Interestingly, in thalassemia, you don't have enough the globulins made, or in this one you actually do make enough globulin, alpha beta globin, sorry. So actually you're turning the porphyrin into the alpha beta globin, but it's not good. That's what's going on there. Yeah, so essentially, in order for a good hemoglobin, you need the good globins to be made, and you also need the iron to be available, right? And iron can be unavailable due to sequestration, or it could also be unavailable due to it's actually lacking iron. So that's that. All right. That's your microcytic anemias. I'm going to go on to megaloblastic in a minute. Okay. On to megaloblastic anemias and nucleotide metabolism. Okay. I don't actually think I have to talk this loud sometimes. It's making my throat hoarse. Alright, let's go on to 18. So, earlier talking about microcytic anemias. Microcytic anemias are talking about failure to make hemoglobin, right? Whereas megaloblastic anemia is instead a failure to divide the cell properly. It's other problems. Here we go. Yeah. So most of it's actually DNA synthesis, which is the big issue with the megaloblastic anemia. So we had to look here at the creation of DNA nucleotides. So we actually had to think about this a little bit more, but I guess the best way to approach megaloblastic anemia is to first start with our nucleotide metabolism real quick. Nucleotide metabolism. It's not the best work that I've done right here, but essentially we're trying to create nucleotides. So we need the DMTP, we need triphosphate nucleotides essentially for purines and for pyridamines. And there are drugs that are involved with these. We talk about methotrexate a little bit later, I think, and 5-fluorouracil. We can talk about that a little bit later. But problems in the creation of these will result in diseases, pretty obviously. So pyridamine synthesis is carried out mostly by an enzyme called CPS2. And problems with CPS2 obviously cause problems with low pyridamines. And similarly, for purine synthesis, it's something called GPAT. So those are those two, and then there's also an important one. So this one will create your ribonucleotides. But in order to change these ribonucleotides into full-blown DNA base pairs, you need to use ribonucleotide reductase. So that's important for, I believe, both of these. So I'm gonna pull up the other one now. Oops. I don't know what I clicked. Okay. Oh, I saved it. Cancel. So I'm gonna pull up our megaloblastic anemia. We can compare these two now. Number 18. Wow, my voice is pretty tired. Jeez. Okay. So the main problem is in megaloblastic anemias, we fail to turn DUMP into DTMP. right? So we can't make T, the pyridamine. So ribonucleotide reductase turns UMP into DUMP. So we need deoxy. We need deoxynucleotides. DUMP, DTMP. We can't use UMP directly. Right? So that's the function of that. And so if we have a problem with that, it's called ADA deficiency. Which is important in SCID. They can't fight off bacterial infections because their immune cells are all dead because they can't make DNA, essentially. If you have a problem with HGPRT, you have leishmanion. It's caused a lot of problems as well. But you have a purine synthesis problem. There's also a big deal not just with formation, but also with degradation. First, I'm going to talk about orotic aciduria. Where you have a problem of converting orotate to UMP. Orotate, I don't have on here, but you can't. So essentially, purine and pyridamines, you have to create your UMP, your CUMP, your TMP, and then you need to change those to DUMP, DTMP, etc., using ribonucleotide reductase. So if you don't even get the first step, you get leishmanion or orotic aciduria. If you can't convert it in the next step, you get ADA deficiency. And then if you can't degrade it, you get gout. And you get PMP through PMP deficiency. So these are diseases I'll probably review more a little bit later, but there's a lot of ground to cover. So I'm going to move on, but in this case, I guess ribonucleotide reductase has already done its job, but you need to change the UMP to DTMP. That's the point of this whole loop right here. And in order to do that, you need a folate. So folate's like your cofactor that's getting changed up this whole time and causing the changes. And you need it to be activated into the N5-N10 methylene form. And this whole process, this whole loop is able to go around and around, right? Only if you're able to generate more of this N5-N10 methylene THF, right? And you need to get it past these sort of waste form THF and DHF. And in order to do that and power this cycle, you need vitamin B. And actually, I would argue the problem is not the to power this cycle as much as it is that the N5 N10 methylene THF gets stuck. It has a tendency to get stuck as N5 methyl THF. And when it's N5 methyl, it just builds up. And then you can't get synthesis. So one of the big problems with that is with vitamin B12. So I'm going to first talk about the diet and the folate portion of all of this. So folate, also known as vitamin B9, and the storage is not as good as it is for B12. So you need to eat it pretty often, and you need to absorb it pretty well. The problem is that you could get a deficiency due to drugs, such as oral contraceptives. And you could also get a deficiency if you had a pregnancy or a neoplasia. And you could also have a folate deficiency, sort of, if you have certain drugs like methotrexate, which is right here, which sort of throws a wrench into this whole process as well. So not having enough of it, having methotrexate, or having vitamin B12 deficiency all throws a wrench in it. Vitamin B12, also known as cobalamin, has a much longer storage period, and it must be absorbed using intrinsic factor, which is from your, if I remember correctly, from your stomach, right? It's your parietal cells. Yeah. Intrinsic factor made by your parietal cells of your stomach, and then it's absorbed at the ileum of your small intestine. So not having enough intrinsic factor gets you pernicious anemia, which can be caused by a lot of stomach issues. On the other hand, so intrinsic factor defect means that like you could have a lot of vitamin B12 in your diet and stuff, but you still wouldn't be able to absorb it. So if you just had intrinsic factor, everything would be fixed. Whereas broader absorptive is even if you fixed intrinsic factor, you would still have a problem. That could be ileal damage. You could also have bacteria or a parasite that's competing for B12. So, Diphyllobothrium latum, the fish tapeworm, or duodenobacteria, through blind loop syndrome. So, blind loop syndrome is when you have it's like a return, I'm pretty sure, from the it's a result of a surgery, sorry. Blind loop syndrome is a result of a surgery that results in a part of your duodenum right here, and it happens when your stomach is essentially cut off from this from duodenal stump, and then what happens is that bacteria can more easily get to your ileum. Right here. So the Schilling tests. I believe Schilling test 1 is you add vitamin, if you add the intrinsic factor. So Schilling test 1 is if you absorb B12 at all. That's what that is. And so both of these are obviously going to fail. Because you have a problem with absorbing B12. And then and the second part is to find out whether you can absorb B12 with intrinsic factor. And so only this one over here fails both tests. And you see quite a lot of other stuff happen because of B12. And the main thing with B12 that separates it from folate is actually you have a dietary, you have a whole neurologic problem going on. Dementia, peripheral neuropathy, like some pretty bad stuff. Kinesthesia is down, so people are not as good at moving. And the thing with that is that if you think that it's folate on accident, instead of identifying it correctly as B12 and you give them folate, then what's going to happen is you're going to have a bigger buildup right here of N5-methyl-THF, which is going to make your nerve problems like real bad. N5-methyl-THF, I guess, is horrible for your nerves. Right. And if you give them folate, it'll worsen it. It definitely is not a good thing. Whereas if you give somebody with a folate deficiency vitamin B12, it's not going to fix the problem, but it's not really going to make it worse either, I don't believe. Part of me is wondering why you don't just give people... Well, yeah, okay. If it's B12, you really don't want to give them any folate, right? Because you want to lower this as much as possible. So you don't want to give folate. You only want B12. Whereas the other one, you could give them folate. You could also give them B12. Doesn't matter, right? So the main thing with megaloblastic anemia is you have a failure of your blast to divide. That's why it's called megaloblastic anemia. And so the result of that is you have red blood cells that are way too big. And you have neutrophils that are way too big. Neutrophils that have way too many lobes. Reason being for that, you must have some sort of DNA formation and damage problem. You have lowered blast action for all blood cells. Makes sense. And your marrow will look weird too, obviously. Why it's hypercellular, I'm not too sure, actually. Let's take a look. I guess it's hypercellular because all the cells are really big, and they're failing to divide and get out of there, you know? Wow, so that's the, quote, popcorn nuclei of a megaloblast. Pretty gnarly. I can't really get... So that's megaloblastic anemia, essentially. Big cells. DNA problem caused big cells. Hemoglobin problem, small cells. So with that, we're done with this section. And I'm going to go eat, but when I come back, I will eventually do your hemolytic anemias. And then go on to innate. So that's it for now. And then I'll be back.